Greetings. Let me share with you certain topics relevant to small intestine for endoscopy nurses and technicians. Let us understand the anatomy of the small intestine, and let me take you through the different areas of the small intestine. It starts from the stomach and goes all the way to the colon. That is small intestine. And it is divided into duodenum. This has a C shape, about 20 to 30 centimeters in length. Jejunum, 2 meters in length, and ileum, 3 meters in length. And the ileum enters into the colon, and there is a valve there, that is the ileocecal valve. So now let us go back to duodenum. And the C-shaped duodenum is divided into 4 portions. The duodenal bulb, or D1, descending duodenum, or D2, D3, or transverse duodenum, and D4, ascending duodenum, that enters into jejunum. So the C-shaped duodenum wraps around the pancreas, and a lot of things happen. You can see D1, D2, D3, and D4. All the structures that are in this area, the bile duct, the pancreatic head, the uncinate process, the superior mesenteric vein, superior mesenteric artery, and the aorta. A lot of things are happening in this area. So let me share with you, when you have a patient with either dyspepsia or diarrhea, you perform endoscopy, because the small intestine is important for not only digestion of certain foods after the pancreas does majority of the digestion, it is also the place where all your digested food gets absorbed. And if there's a problem with the small intestine, you develop diarrhea and malabsorption. So whenever somebody has diarrhea and malabsorption and weight loss, you perform examination of the duodenum. So once you go through the stomach and put your scope at the pyloric ring, you watch the duodenal bulb. This has no features, no folds, just as a small featureless space. From the D1 or duodenal bulb, as you enter into the descending duodenum or D2, now you see circular folds. And circular folds tell you that you moved from the D1 to D2. And then as you withdraw the scope, the loop in the scope reduces and the scope goes forwards into the D3. Sometimes you can push further and go to D4. So in every patient with dyspepsia and diarrhea and malabsorption, you take biopsies to rule out celiac disease and other causes for malabsorption. How many biopsies should you take from the descending duodenum and transverse duodenum? At least 4 to 6 biopsies. And it's best to take biopsies, one biopsy at a time, from the at least 4 to 6 biopsies from the descending and distal duodenum. And also you take biopsies from the duodenal bulb between 9 o'clock to 12 o'clock. This is where you get the maximum yield for changes of celiac disease. When the pathologist looks at the biopsies, he is looking at nice, tall, finger-like structures called villi, and if there are excess of lymphocytes in the villi or not. When there is celiac disease, these villi get stunted or atrophy, and there will be a lot of lymphocytes. That's how one diagnoses celiac disease or gluten sensitivity. You can also see a lot of these things in other conditions where the villus can change and the number of inflammatory cells can change or increase. When you don't have villi, you don't absorb. That leads to malabsorption. And if you don't absorb your nutrients, you develop malnutrition and changes from malnutrition. So now let us look at a certain pathology. So here is the duodenal bulb looking normal, and if somebody develops an ulcer, this is how an ulcer looks like, a duodenal bulb ulcer. Sometimes you can see a nodule that is submucosal, typically carcinoid tumor, or rarely you may see cancer. As you go into the descending duodenum, you may see polyps or adenomas, or lots of adenomas in familial adenomatous polyposis, and sometimes in cirrhosis patients, portal vein thrombosis, you may see varices. Like varices in the esophagus, you can see red veil markings and cherry red spots here also. So I hope this is helpful. Thank you.